Hi, everybody. I'm Matt Lungren. Thanks for having me here. I'm the Chief Scientific Officer at Microsoft Health and Life Sciences. I also have academic and clinical responsibilities at Stanford University. And I'm really excited to be with you all today. I'm going to talk a little bit about AI, where things are going, and a little bit about our impact that we're seeing in healthcare, in addition to some food for thought for the future. But first, just kind of understand why, as an academic clinician at a large technology company, and kind of what do I do? And just at a high level, my group actually sits across this large company, and we're sort of a horizontal group. And what we focus on is bringing innovation, finding it around the company, whether it's in our research divisions or our product R&D, et cetera, and bringing that into a healthcare application, but also the other direction. So taking things that we're seeing as gaps in the healthcare products or even in daily practice and finding pockets of innovation either with our internal groups or even with our partners to say, can we fill those gaps and kind of translating those needs? So it's a very cross organizational role. And as you can see from the quote, we really believe in adaptability, particularly in the era of AI. But as a tongue in cheek, when I sort of try to describe what I do every day, this is probably more realistic, which is that it's a big place, and trying to connect the dots, keeping track of all the AI gets pretty hectic. So this is maybe a better example of kind of how my day goes. All right, and so in getting invited to this, so I'm really thrilled to be here. And a lot of people may not know that I do have ties to the veterinary world. I did want to show my bona fides. This is a paper I published way back in the pre-GPT days with Diane Wilson, who's an AI veterinarian and does a lot of work in this space. But we really tried to make a thesis here that so far seems to be coming true, if I don't mind saying so. And some of the points that we brought up with regard to the juxtaposition of the veterinary AI world and the human health AI world, there's a lot of overlap, but in my opinion, and again, the case that we made in this article is that we're really going to be looking to you all in the veterinary world to lead the way. And there's some convenient things that kind of fall out of that, which include the data that you use, the formats that you use are the same. Some of the needs and the burnout and the shortages of the workforce of the expert clinicians, also a similar pattern that we're seeing. And then finally, the ability to align incentives to build and deploy systems that actually drive use cases in the veterinary world are much more friction-free than at least we see in the human world. And so we look to you to guide the way. So no pressure, but we're hoping for you to do so. All right. So just to set the stage, I think a lot of you have been wondering about what's going on with AI. Maybe some of you are keeping track very closely, or maybe some of you aren't. So I just wanted to kind of set the stage and put everything back in perspective. I'm going to show you a clip from Bill Gates speaking with David Letterman from 30 years ago. And to give you a sense of what he was talking about, this was an interview about this new thing called the internet.
This internet thing, do you know anything about that?
Sure.
What the hell is that exactly?
Well, it's become a place where people are publishing information.
Right.
So everybody can have their own homepage. Companies are there, the latest information. It's wild what's going on. You can send electronic mail to people. It is the big new thing.
Yeah, but it's easy to criticize something you don't fully understand, which is my position here.
Go ahead.
But I can remember a couple of months ago, there was like a big breakthrough announcement that on the internet or on some computer deal, they were going to broadcast a baseball game. You could listen to a baseball game on your computer. And I just thought to myself, does radio ring a bell? You know what I mean?
There's a difference. You can listen to the baseball game whenever you want.
All right. Do tape recorders ring a bell?
All right, so you kind of got a sense of this was Bill trying to describe this new phenomenon that we're all, of course, very familiar with. Well, so just about 30 years later, Bill showed up to another talk show, a little grayer like myself, but wanted to talk about this new thing that we're seeing in AI.
Everyone's talking about AI, and that's the big topic. Everyone's like, how's it going to take over, and all this stuff, and it's bad or it's good or we don't know. What are the pros and cons for, in layman's terms, for someone like me?
Yeah, so the era we've come to is sort of the vision that computing was expensive and it basically became free. The era that we're just starting is that intelligence is rare, a great doctor, a great teacher. And with AI, over the next decade, that will become free, commonplace, great medical advice, great tutoring. And it's kind of profound because it solves all these specific problems, like we don't have enough doctors or, mental health professionals. But it brings with it kind of so much change. What will jobs be like? Should we, just work like 2 or 3 days a week? So I love the way it'll drive innovation forward, but I think, it's a little bit unknown.
Yeah.
Will we be able to shape it? And so legitimately, people are like, wow, this is a bit scary. It's completely new territory.
I mean, will we still need humans?
Not for most things. We'll decide.
I mean, hosting a talk show, definitely. You're new, but really?
All right. So again, we kind of see this we're beginning of a new era, and the projections are not as crazy as they might sound to you, that we may not need knowledge workers for most things that we currently need them for today. So let's kind of take a little trip on how we got here, at least the best that I can convey to you. So this is kind of the Big Bang moment, right? This is the AOL disk in the mail. This is the internet browser for AI moment, right? When all of you probably have at least undoubtedly statistically have used GPT at least one time. It's the fastest adopted consumer software application in history. And the reason I like to display it the way I have on the right is it's juxtaposed against these other applications that are kind of meant to hack your dopamine and trap you into these software programs. And GPT doesn't have any of that, right? It's insanely popular, but it's not hacking anyone's dopamine. It's giving the entire world access to the most powerful AI on the planet. And that is driving a lot of interest and a lot of business use cases. And if we kind of look at where we are today, most of the consumption of what you would call generative AI or AI now, I guess, is kind of taken over, is really with the GPT and some of the things that we serve at Microsoft, and that's really a part of that being first and actually keeping the lead as sort of things evolve. And there's a few others on this list too, which I would argue have very powerful use cases as well. But if you ask someone, at your next dinner party, what is Claude AI? I don't think you're going to have a lot of brand recognition there. So you really see how mindshare has really captured the imagination, and folks kind of equate AI to GPT at this point. If you look at the broader internet traffic, it's kind of astounding that something that's less than 3 years old is already in the top 10 sites and moving quickly up the ranks. The other notable thing here I always point out is I always give my dad a bunch of heat for having a Yahoo email still, but apparently he's not the only one because it's still a top 10 website. So for what it's worth, but you can see that there's just this constant rise of now 500 million weekly active users and rising, and over 2 million enterprises are using GPT in their business operations. So how did this all start? And really, there's a lot of ways to slice this, but at a high level, there's three main ingredients to the AI models that you're seeing today. There's compute, there's the size of the data set, and then there's parameters, or the size of the model. And in various combinations, this kind of forms the secret sauce at very, very high levels of scale to create what we call the scaling laws. And this is just the way that you can see as sort of shown here, where you get exponential input, so exponential increase in compute data set size and parameters leads to linear improvement of, in this case, a loss function, but really improving the ability of the model to solve tasks. And in this case, of course, the fundamental task is predicting the next word. So understanding the language that we all use every day. And that scale is hard to really represent in sort of graphical form, but to give you a sense, there are more construction workers that work for some of these cloud companies than there are engineers. There's a massive operation. This is actually a physical operation that requires a ton of work and a ton of resources to build them at these increasing levels of scale to get that improvement in performance. And so as you take a step back and kind of look at the levels of intelligence and the improvement over time, you see that GPT-4 really stands out in a class of its own, right, initially. And now you're starting to see this plateau, this clustering of models that are coming from open source and other companies, et cetera, where you might argue that things are starting to kind of converge around what we would call this GPT-4 class level of performance, which in some cases is really, really amazing because now we have all these options and the cost and the ability to use these models is becoming increasingly easy. But it also makes a lot of folks wonder, are we hitting a wall? Is this investment that we're putting into quote unquote AI intelligence not going to bear continuous fruit over time? And so, again, the path here is really to think about, can we get to AGI, this thing that kind of Bill was hinting at? Can we get to a place where a software, right, could actually do the work of a knowledge worker, of an educated knowledge worker? How do we get there? And if you were, paying attention to the headlines last summer, or at least into the fall, a lot of folks were starting to say, hey, we're seeing this kind of leveling off. We're not seeing this big, leap to a new class of intelligence. Maybe this is as good as it's going to get. And frankly, to be fair, that is still pretty powerful. The capabilities of GPT-4 are still relatively underexplored. But nonetheless, it does beg the question, how do we get to that next level that Bill was talking about? Is there a path? And so almost as if on cue, right when all these, folks, all these conversations were starting, a new scaling law appeared. And this one is really interesting. It's essentially time. And it put another way, it's allowing the model to have more time to think. And so the analogy that I like to use is, imagine that what we were doing before is if we had an hour to study and take a test, we were spending 59 minutes studying and 1 minute taking the test. That was the old paradigm. We're putting a lot of energy in that 59 minutes. Now, what this is saying is that if we actually expand the time to take the test, to write the test, we actually also have what is essentially an unlimited upper limit in the performance of these models. And that's called test time compute. And it's really, really, really powerful for a lot of reasons, also because it's less resource intensive. And just to kind of put a finer point on this, Noam Brown, who's the one of the geniuses at OpenAI, has been thinking about this for some time and basically has said that 20 seconds of additional quote unquote thinking leads to performance gains that would have required 100x training and compute and all those other resources we talked about before. So basically, you'd have to build a data center the size of Wyoming to get the same performance as you can get by letting the model think for longer. It's incredibly profound. I can't overemphasize how big of a deal this is, and we're already starting to bear the fruit of this. So if you've seen some of these, and I will admit to you that the naming conventions are a little bit confusing, but this O1, O3, and soon you'll be seeing additional thinking models. They immediately jump above the performance of some of the biggest models that we had before. And typically, these thinking models do incredibly well on tasks that have a well-defined output, so math and coding. And that's why you're starting to see a lot of chatter about someone speaking in natural language and building a software application. This is unprecedented territory that we're entering into. And again, to kind of wrap your head around what's really happening under the hood for those in the audience who might be coders or familiar with some of the computer science concepts here, it's a little bit like recursion. And again, I learned to code in my later age, so it was not easy for me. But recursion in particular was a very hard concept for me to wrap my head around it. The idea that I could write a function that refers to itself to solve a problem. That was hard for me to wrap my head around. It's kind of what we're seeing here. It's allowing the model to kind of, as you can kind of see from this funny example, sort of say the answer, wait, hold on, let me think about that a little bit more. Okay. And again, it's like that analogy I gave you, which is give yourself more time to think about the problem and take the test. You're likely to arrive at the better answer. And that's kind of the intuition here. So as you build from this, starting from a really powerful base model, and then over time giving the model the ability to think and improve itself, you're really getting to a place where the performance is starting to go to limits where we didn't think possible. This particular benchmark was considered unbreakable for a long time, and these are really gnarly coding problems that the models were increasingly now able to solve. And this has been profound for software development in particular. But a lot of people in the community argue that this isn't really a path to AGI. A very intelligent human can be intelligent without having, knowing how to code or write some really complicated math proof, right? So they created this benchmark called the ARC-AGI benchmark. And this is really an interesting benchmark because as you can see from these patterns here, the purpose of this benchmark is to test the fluid intelligence of a human, right? And most humans with a STEM grad education get 100% on this test. And that's what you want. You want to be able to identify intelligence in humans, be able to manipulate concepts, find patterns and new things. But the models historically have done really, really poorly at this. And that was the goal, is to show that there's really big gap between what we would see as coding and math and some of these things that computers can be good at versus what humans are good at. And if you look at this benchmark over time, that's actually true. We've scaled up from GPT-2 to GPT-4, massive amounts of compute, huge jumps in performance and lots of benchmarks, barely moving the needle at all on this benchmark. That is until the thinking models. And now we're starting to see these thinking models again saturate these kinds of benchmarks too. And this is why folks like Bill Gates and many others who are luminaries and have thought about this a lot longer than I have are starting to say things like we are getting to a place where we need to think very clearly about what is a post AGI world, what does a knowledge work being free really look like for the things that we do every day. I will make one call out, which is interesting because even at Microsoft, where we have all kinds of resources and lots of fancy models and all kinds of compute, we still fight over the best models internally. In fact, there's one gentleman who is sort of in charge of making the decision of which project gets to use the best models internally. And so I'm just going to play this funny clip of what it feels like even for us who want to use the really, really awesome models, but they're a little expensive and we're not getting the answer that we want. So there's this funny meme that went around, and I'll share it with you here.
No, no.
So I can't overemphasize how real that is internally, because a lot of people want access to this really, really powerful intelligence. We do know that will become increasingly available, but we want it now. We want the latest technology. All right, so sometimes it's hard to look at benchmarks and really get a sense of uh, how good things are getting just by looking at numbers and benchmarks maybe you haven't heard of. And so I like to show visual examples too. So there is a strange benchmark called the Will Smith Eats Spaghetti benchmark. And about a year ago, this is what it looked like when you asked the model to create a video of Will Smith eating spaghetti. This is what you got. It's almost like a dystopian nightmare of Will Smith trying to eat spaghetti, right? But just again to show you the performance improvement, just about a year later, this is what we're, and this is by the way in February, this is what we're starting to see, right? A lot more fluidity. We're way past the days of six-fingered humans like showing up in these models, and that is really powerful statement. Now, a lot of people would argue with that and say, Matt, Will Smith is really all over the internet. He's been in lots of movies, lots of TV shows. These models know what Will Smith looks like. And I think that's a fair statement. So let's take an example. This is a photograph of myself with a friend of mine who's a Wisconsin Badger fan. And there's no way the model has seen this. And I use this image and I put this text prompt in to have it make a video. And I said, create a video where the guy in the gray shirt is explaining to the guy in the orange shirt that Taylor Swift is way more talented than the Wisconsin football team. And here's what happens next. All right. So as you can see, right? So it's not perfect, right? It had some distortions, but there's some really interesting things, right? With the physics that the model is intuitively learned. The AirPods stay in his ears. There's people in the crowd that start to look over at what's going on. I can't land a punch. All this stuff is real, right? But then there's some things that are not perfect, right? Some of my distortions, and then the man in the back's glasses disappear. But you're getting a sense now that this technology is rapidly improving within a very short period of time. And this has economic implications. This is just not just goofing on your friends and family. If you remember back in the mid 20 teens, one of the Fast and Furious sequels, I don't know, 20 or 30, whatever number it was, where they had a tragic accident and Paul Walker passed away. He's the star of the movie. And they needed to paint his face digitally on about 12 minutes of that movie to complete the film. Well, that took about a year. It cost $50 million and 350 people worked on that project. Think about that. Today, a random person on the internet took the opening credits of Severance and said, I'd rather have Keanu Reeves as the actor. And took a few minutes of time. Any of you can go on to many of the online tools and do this yourself if you like. And you can start to see the economic implications. And again, this ties back to what Bill was saying. This is accelerating really, really fast across many different angles. And we need to start thinking about what this means for the future of work. And again, if you don't take my word for it, Tyler Perry is much more successful than me. He's made some decisions based on this technology too. And in this case, to not invest a planned $800 million into a digital media studio after seeing some of the capabilities of these text to video models. So it's starting to really have real impact. Okay. So let's think about the work. And again, we're going to get to healthcare in just a second, but this is a good lead in because this is not just about taking care of folks, taking care of our pet family. This is really about our day-to-day, the things that we rely on the rest of the economy as we function as a society, essentially, right? So this was data from a survey that was done of 30,000 knowledge workers. There's a few interesting things here, but one I'll highlight is the fact that more than 50% of the time, this study was done last March, said that they are using it every week for their jobs. On the other side, almost everyone said this is going to really benefit them. That's pretty profound. One model that was not built for any particular job is going to benefit, across the sectors of the economy, everyone's work, particularly knowledge workers. And just a few months later, another survey was done that now found instead of half, it's actually 2/3. So 2/3 of knowledge workers are using this technology in their day-to-day lives. Now in healthcare, it's a little trickier, right? It's harder to get data on this, but one survey that was published by the NHS looked at their general practitioners and asked them, are any of you using GPT in your practice? And as you can see here, around 20% in this case, excuse me, use the public models like Bing and ChatGPT and Bard, et cetera. But what gets interesting is that, what you expect them to use it for, which is maybe summarize a document or maybe write a prior auth form or something like that, they're actually using it in a large majority for clinical decision support, right? These are regulated use cases. And this raises a lot of questions in our community. But we're not really that secretive about it. You can go onto TikTok or any social media platform, and doctors can't wait to tell you about how they save time using some of these models. And there's a lot of sharing going on. This is just an example that went viral about a year ago of a doctor using it to knock out all his prior auth work, right? And when you start to dig into some more of the data on what physicians are using it for and how they're using it, a lot of them are finding it that it's really, really helping them in their clinical practice. And many are optimistic about this really accelerating them across the use cases. So not just for administrative work, but for clinical work. And this is really going to make a profound shift for all of us in healthcare. And anecdotally, I don't think I've walked into a hospital in the last 6 months where I haven't seen someone typing something into GPT or talking to GPT about a patient case or about a question that they may have. And this is really starting to cause a lot of questions to be raised by the leaders and the administrators, and certainly those of us in the education community. The AMA looked at this as well, and they found that about 2/3 of docs are now stating that they're using AI in some capacity. A lot of this is with these ambient note solutions, which I'll touch on, but a lot of it's for things that, again, quick, can you give me a differential diagnosis? Can you summarize this this long discharge summary for me? I need to get the bottom line. These are the kinds of use cases that are happening every single day. And there's a reason for that. Because again, these models are really, really good at writing a poem or doing your kids' homework, but they also are incredibly good, particularly now the thinking model, at medical benchmarks. Now, this benchmark, as I'll talk about, is not perfect. This is a MedQA benchmark. So this is essentially the step one exam for those of us in human healthcare, multiple choice tests to very complicated vignettes of care. And the graph on the left is trying to show you that, yes, there are efforts to create models that only are trained to do healthcare, but the models that are not trained to do healthcare, like GPT-4 and then O1 now, the thinking model, they don't need to be taught specific, they don't need to be trained on specific healthcare text to be able to pass or saturate these benchmarks. That's a very profound finding, right? they were not intentionally meant to do this, and yet they're crushing the benchmarks. And when you start to compare it to physician performance, the narrative that I've been using in my career in health AI has always been that a human physician with AI will be better than either alone. We've been saying that for a decade, but we can't find that evidence really shaking out. And we tend to keep finding these kinds of results. This is a result of using O1, that thinking model I mentioned, GPT-4, physicians with GPT-4, and then physicians by themselves using the internet. Now, these are definitely challenging clinical cases, and it's a little bit of a contrived setup, but I'm still going to argue to you that we haven't found the optimal way for physicians and other healthcare workers to work with these models to make sure that the performance of both is better than either alone. In fact, we keep finding that leveraging just O1 by itself is better. And how do we grapple with that, and what do we do next is still a big question in the research community. The other thing that comes up is hallucinations, right? Because if these models are confident and they're confident and wrong, it can be pretty dangerous. And we're not going to be able to touch on in this talk all the implications for our patients and certainly the folks in the community that are using that are not experts. But what we're starting to see is that the hallucination rate, particularly with the thinking model, is gone down precipitously. So if you've used these models for healthcare use cases when it was 3.5 and maybe the early days of 4, and you haven't been using them since, particularly haven't used the thinking model, it might be time to check again, because the results like this we're seeing over and over again, where the hallucination rate, as you can see, is not measurable, right, for the O1 model. And that's kind of the sort of greenish colored icon where you're seeing there's essentially no hallucination across these critical categories. That's also very profound as we think about the application in healthcare. We worked with Stanford quite a bit. Of course, I still do some teaching and work there, but together we put together a better benchmark, because the criticism against the multiple choice test benchmark, it tests concepts, right? But multiple choice isn't really what I do for a living, right? So we put together real data and real use cases together with our colleagues to actually try to judge the performance of these models in actual real world settings. And we've made this very public. We put a public leaderboard out, and we're adding models every day because there are so many. Folks are needing to kind of understand, where do I start and which model should I use for what use case? And so again, you're welcome to check out the website. It's being updated regularly, but you can see that the general models that maybe you're familiar with are kind of falling into the categories that you'd expect based on the other benchmarks. But nonetheless, it's reassuring to see that models we're testing hallucination rate, we're testing for actual clinical use cases that physicians are using these things for. And again, it's not like we're the only people exploring this. I would be shocked to hear if any of you in the audience doesn't have a medical journal that you've opened up in the last year that doesn't have an article about AI use, right? New England Journal even started a new journal, which is unprecedented for New England Journal of Medicine, just for AI. And this slide is somewhat dated now, but there are over 2,000 citations already just on AI in various health applications. And this is what we would probably confidently say is an ecosystem transformation. So it's not just the general use, it's not just a few solution providers. The entire community is rallying around how can we actually optimally use these, and where do they work and where do they not work? So why do we care so much about this in healthcare? Well, I don't have to tell you, but as an ambassador from the human world, burnout is real. It is a massive crisis that we're facing, and the pandemic only added fuel to that flame. I talk to clinicians all the time who tell me that they're looking for an exit door to get out of healthcare. And that's a problem, right? As we have an aging population, we have more frustrated physicians. And a lot of that is tied to administrative burden. And when folks say, oh, it's just a little paperwork, why would that cause a physician to burn out? I always cite these kinds of studies, right? This was done by Becker's, asking different specialists across the healthcare ecosystem, how many hours do they spend doing things that are not direct patient care? This is shocking. If you had told me when I was applying to med school that 20 hours a week I'd be spending doing paperwork and not taking care of people, I don't think I'd do it. And I certainly feel it now in my specialty of what I do in interventional radiology. We're very clinically focused, and I'm doing a lot more paperwork than I did in 2003. And this is one of the chief causes. There are other reasons why access to physicians, the electronic health record, all these other reasons why the burden of taking care of patients and the practice of medicine has gotten very difficult. And so when folks look for use cases to apply these technologies, I often tap this sign. Now, this is old data, but we trot it out often because I would wager that that purple line has not gone down in healthcare in the last 10 years. In fact, I guarantee you it's gone up. And if you're looking for use cases to apply this general knowledge technology that is increasingly good to address some of the major burnout and crisis issues we have in healthcare, this is the place I would focus first. I would call these low risk, high value use cases, and then really talking about the massive amounts of administration that we do in caring for our patients. For those in the investment community who I work with, the question is always like, well, what's the market size for this? And I love that someone's done this work already for me, so I don't have to. We're talking about up to $1 trillion a year in the US healthcare system alone is spent on administrative work. So there's plenty of opportunity if I'm being a little crass here to say that if you need a business case to tackle this, it's right in front of you. So, okay, so what are folks doing at an institution level? And I think I'm just going to highlight a couple things for you. One is you can't have your whole workforce potentially using these public APIs and with the risk of maybe exposing patient data. At least in the human healthcare world, that is essentially a red line, right? And so a lot of institutions, NYU was the first to publish about this. They said, listen, we want to create a HIPAA compliant access to the best models that our workforce can use, whether they're administrators or nurses or doctors or whatever they do for a living. But we want to have an environment where we don't have to worry. And so they set up this GPT-4 environment inside. It looks just like your chat environment, but it's inside a HIPAA compliant hosted instance. And the interface looks just like this. And again, I refer you to the paper on this. They did a phenomenal job describing this. We have more than 50 institutions now that have done this. And it's really moving the needle in a couple ways. It's allowing the top level to relax a bit, not worrying about PHI and potentially security issues. And the bottoms up workforce is getting more literate because they're encouraged to use it. And the more you use it, the more intuition you build about what they can do to help you with your day to day. And that's really powerful. And then finally, it's allowing the administrators to say, who's using it and what are they using it for? Because you might decide at the top level, administrators, 2/3 of administrators are using it for this use case. We're going to operationalize that. That's a powerful data set to think about. But when it comes to actually software, like what is off the shelf ready to go that I can use to address some of the problems that we have in our clinic, in the human healthcare world, there's no better example than what we call the ambient note solutions. The way this works is a doctor and patient chat. That chat gets recorded into text. That text gets turned into a note in the EHR that the doctor can quickly sign. Now, what's nice about that is that for the last 10 years, I haven't been able to look my patients in the eye very much, right? Because I'm hurriedly typing on a computer. It's called keyboard liberation is kind of how we're looking at it. And this thing is absolutely catching fire. We have also been working with our systems of record. So in the human healthcare world, Epic is one of the largest EHR providers. And working through UIs that clinicians use every day is a huge, huge unlock because they understand the workflows, where the pain points might be, and injecting generative AI in a responsible way into that is really moving the needle. What we've done is we've essentially taken this Dragon Copilot ambient experience and accelerated the capabilities. So now you can talk to your notes, you can talk to your chart, you can use your voice to interact with it almost as a one-to-one copilot. It's really, really powerful unlock for physicians who are hoping to get out of the business of doing administrative work and back into the business of taking care of patients. And there's definitely equivalence in many parts of healthcare. We're seeing time saved. We're seeing burnout reduced. Anecdotally, I hear people tell me they were going to retire because they were tired of the paperwork. And with this solution, they're not. I rarely hear that kind of feedback about software from clinicians who are, let's be honest, tend to be a little bit curmudgeon and you might even call Luddites. And here we are seeing doctors of retirement age adopting this, embracing this technology because it's really saving them time. And this is just the tip of the iceberg, folks. There are so many use cases that leverage general knowledge and text that we can use to leverage all these different pain points that doctors and nurses point out is obstructing their ability to give good care. And so as we start to tackle these with our partners, we see startups, lots of different other companies are working on this. I am more hopeful than ever that we're going to start to bend that curve down of administrative burden and really unlock the human patient interaction once again. But one thing I want to point out before I close is that we're doing a lot in language. Everything I just showed you was medical language, text, okay? That is powerful. But for many of you in the audience who are familiar with the broader enterprise and particularly those of you who work in other specialties, text isn't all we use to take care of patients. And a step further is most of the data we have about our patients isn't in text. It's actually locked up in pathology slides and radiology and genomics. What about those modalities? Can we not have an ecosystem where we can start to process that as well? The good news is that, as I showed you at the beginning with the text and image, that's a convenient thing because transformers, or the architecture that we build all this off, can process text, it can process images, it can process videos, it can process waveforms. That's really powerful. And so we do have a very convenient architecture to start to tackle some of these challenges. But the issue is that the off-the-shelf models, you can take a picture of your washing machine or your broken bicycle and talk to GPT-4 today and ask it questions about that image, and you can get some answers. But let me show you what happens when you put a very basic medical imaging image into the model and how well it does. So I'm going to take this radiology 101 use case, a chest x-ray with a pneumothorax, which I've conveniently highlighted for those of you who are not radiologists. And we're going to take this and we're going to put it in the GPT-4, ask it to look at the image and write a radiology report. Let's see how it does.
I'm going to begin by uploading the chest x-ray to GPT-4o. Leveraging the voice capabilities of 4o, I can speak to the model and ask it questions. Can you write the findings section of a radiology report?
The lungs appear clear and well aerated. The heart and mediastinum are within normal limits. No evidence of pulmonary edema, pneumothorax, or infiltrates. The bony structures are intact.
Do you see the right pneumothorax?
I can't make it out. I do not see a right pneumothorax in this image. It is possible that there may be a small pneumothorax that is not visible on this image, but based on what I can see, I do not see evidence of a pneumothorax.
All right, so a couple things to point out. It totally can't see the pneumothorax, but that's a problem, right? So it's not able to competently process the image. But it knows what a radiology report is. It knows that it can't see it, right? And it knows the concept of a pneumothorax. This is good raw material to work with. Now our objective is to connect its understanding of those concepts to the actual imaging data. That's the gap that we're going to try to fill. And this has been the North Star for a while. Okay, so we published this blog at Stanford almost full 2 years ago, where we need to figure out a way to get real world data into a foundation model so they can process them just like a human expert would across specialties. And then have a system where anyone in the healthcare environment can interact with that model and get the thing that they need done. And that thing that they need done may involve looking at a pathology slide, looking at an ECG. How do we get this competency connected to what it already knows about those concepts, which I've already shown you is currently possible? That's the question. So the easy answer is I can take that really big model and I can shove a bunch of radiology and pathology data in there to teach it that. That is one way to do it. And as we look at this kind of intelligence curve, you can see that the medical text comprehension is going essentially parabolic at this point. So it's improving, but the ability to process images and genomics and pathology is not improving as well. And this is that gap that I was trying to describe to you. The knowledge is really up here. Imaging processing for medical is down here. Again, if I took that big model and I did that, it would probably be pretty good. But the problem is then what happens when the next smart knowledge text model comes out a week later, 2 weeks later? Do I need to retrain that big model again? It starts to get really expensive and confusing. The other issue is that no one entity has a ton of data in every single modality enough to really do this at scale. In other words, do I have competencies in radiology, pathology, but I don't have genomics, or I don't have ophthalmology or dermatology or cardiology. How do we really bring this into an ecosystem? And how do we decouple the need to train the big model with all this data from the need to teach it how to look at it? That's really the ultimate question that we're posing. And so what we've done is we've said we're going to take a modular approach to this. We're going to learn the embedding space of all kinds of biomedical imaging data, cell imaging, pathology, radiology, ophthalmology, et cetera. And then we're going to use adapters to attach it to whichever model we want. Now, it could be an open source model. You've heard of many of these maybe logos before, but the idea is that we've now made this modular and can focus on bringing in the competencies of the modality separate from the text. This is really important to sort of think about. And so as a use case, we said, well, let's take the image embedding model that understands chest x-rays and let's connect it to one of these general reasoners and let's see how it does. And what we found is that not only do we get better performance than throwing all this stuff into one giant model, but we can also do it more efficiently. And this is just scratching the surface for us because we really just did this as a thought experiment with a lot of the open source data around chest x-rays. And there's a lot of things coming down the line that's going to allow people to start to build systems that can leverage this other type of data. And that will unlock, in my opinion, the healthcare applications of the future. So let's go back to our model. This time we'll show it. We'll show a model that's actually been connected to the understanding of chest x-rays. And now let's see how it does, just as a proof of concept.
I'm now going to upload the same chest x-ray that we gave to GPT-4o previously to Project Clarity. Can you write the findings section of a radiology report?
The lungs show a very large right-sided pneumothorax. The left lung remains clear and well aerated. The heart and mediastinum are shifted to the left due to the pneumothorax. There is no evidence of pulmonary edema or infiltrates. The bony structures are intact.
How should I manage this patient?
If the patient indeed has a large right pneumothorax, immediate management is crucial to prevent complications, especially if the patient is symptomatic. Here is one general approach you could take. Assess clinical stability, oxygen therapy, chest tube placement, monitoring of the patient, admission to the hospital, and finally surgical consultation. I would be happy to explain each of these more in depth, but would you like me to contact the referring provider to notify them of the finding first?
Now, this is pretty profound. There's a couple of things I'm just going to point out. Obviously, it saw the pneumothorax. It was able to write that report. So we've connected the imaging understanding to the knowledge. But it also knew that the persona, because they were asking for a radiology report, was probably a radiologist. So then it's suggesting that, do you want me to contact the referring provider, right? I mean, this is the kind of intuition. This is where the magic starts to happen between connect. Now imagine in a resource limited setting, imaging is still 80% of clinical visits, right? And how do we actually go to places that don't have enough medical imaging experts and start to help advance care? Now think about the ability to interact with the model, ask questions about the image. You start to see where the possibilities start to really dovetail. And this for us is the North Star. And building systems that allow us to do this alongside the powerful improvement in the tech space is really what we think is the way to go. And so again, we've actually launched, and this is all open source. So you all welcome to check this out. And we have been working with some veterinary specific groups that have taken some of these pre-trained models across different modalities and started to build systems that can accelerate the work to build AI use cases in the medical imaging space for veterinary care. So this isn't just a total thought experiment for us. And we're seeing that because we've open sourced these models and we bring in partners, it's not just us. We've actually built an ecosystem that allows people to build those applications of the future. These are just some of the partners that we've launched with. We have many more coming, but you'll notice that there is one veterinary provider that's partnered with us. So it's a very exciting time for us to start to see this ecosystem form. And we begin, because it's an open platform, we invite anyone to come to the Azure AI Foundry, check out the models, build a use case, enjoy hopefully the applications that you're developing. And in the future, as we see this really vision start to take shape, can we learn the language of all of biomedicine? This is a bit ambitious. But if you think about the connections between the preclinical, the science imaging to the clinical, That's the precision medicine approach, understanding the language of biology and being able to interact with these systems for new discovery, new development, and frankly, new delivery care approaches is really where we believe the field will go. And we're just really, really proud to have an ecosystem to do that with. So with that, I will close. I'll take some questions from everyone, but I'm happy to stick around to do that. Thank you so much for having me. I really, really appreciate it.
Thanks so much, Dr. Lungren. We really appreciate your excellent talk. But thank you so much for joining us for the Q&A. We have our Slido tool, so our participants around the world, as well as that are in the room with us, can enter questions there, and we also have microphones in the room as well.
Great.
All right, so I'm going to read the first question so we can get started with that. This is a question that got a lot of likes, a very popular one. So these tools are really only as good as the data that they can mine. And in veterinary medicine and all of the disciplines, but in particular in nutrition, there's so many misconceptions and lots of incorrect information out there. So how do we use that mining aspect of it to increase quality control and to use expert opinions over some of those unsubstantiated information that's available?
Yeah, I mean, this obviously this is a great question, and it's probably even, you know, there's corollaries back to the days of the early internet, right? Where we used to say, you know, your Google search is not a replacement, you know, for my medical degree kind of thing, right? I think that's fair. I think one of the things that we've learned with the reasoning models in particular is they tend to sort of be a little bit more, I should say, less gullible. In other words, they're crawling the web, even if the ones that have access to the internet. You saw some of the early versions of that where you just connected a regular model to the internet. It would get fooled by silly things like spoof sites, or, you know, the famous one I think is Gemini was making up a sequel to a movie that doesn't exist, right? It was telling the user that this movie's coming out. So there's that side of things, which I think is gradually getting solved. But to your point, the things that we worry about specifically are, hey, if they ask for like a dosage recommendation, and I'm in pediatrics, which is kind of a cousin to veterinary medicine in the sense that my patients don't always talk back to me. And, you know, I have to do weight-based dosing, right? So like, I can't have that mess up, right? And so there are some of the things that we're, you know, working on in terms of this idea of agents is the model itself. You've asked the question, it knows what tool to use. So in a simple way, a calculator or some deterministic tool to then bring that answer back. That's one way to do it. But in terms of like knowledge and sources and things like that, we actually ground it to internal documents. So for example, if I ask what is the third line antibiotic, you know, that my institution, you know, says is okay, if it goes on if it uses its own knowledge of the web, it's probably still going to potentially be wrong. But I can ground it with retrieval augmented generation, which you may have heard of. And there's a lot of different ways to do that. But actually have it bring back the answer and then make it a clickable link to take me to where it got that from. And that has been really, really powerful. And so and again, I didn't get to this much in the talk, but we've already moved past a lot of what I already said, even believe it or not, into agents, right? And now we have almost like encapsulated personas that kind of go off and do work for us and come back. And that has been, including tool use, including look at my documents. I don't have time to run through, you know, 500-page PDFs to get an answer, but then tell me where you got that. It's sort of that trust but verify. So I can't say it's all fixed, and I do worry about patients and maybe those who aren't able to judge the information as being good or not, you know, potentially going off the rails. I am concerned about that for sure. But in terms of how we are thinking about this for a clinical use, we do have lots of opportunity to guardrail that.
Yeah, thanks for that. That's somewhat reassuring. So we have a question in the room. Is that Dr. Snyder back there?
It is. So my question, I guess, is related to that one. Do you give room for patient input, for example, diet information, and of course I'm a wearable guy, so smartwatch data, things like that, to be inputted into the system?
Yeah. Yeah, that's absolutely, there's actually, I mean, at least in my universe, there's a ton of companies that have tried to take that front door. Partially because, like, I mean, as you know, as a patient, at least for in our world, right, or you are a patient, you fill out one form. Well, first you fill out the form when you get the appointment. You fill out another form for reasons you don't understand at the appointment with the same information. And then you go in with the nurse practitioner, and they ask you the same damn question. Like, you're doing this, it's brutal, right? So
Yeah, blood
yes,
pressure,
so I think that is absolutely a very fruitful area that folks have addressed with this sort of agent that doesn't try to make diagnoses, right? Its only job is to either make an appointment for you and answer those questions. And if you seem to not be able to do that, you can even do it via voice, right? So if you don't like to chat, I mean, obviously our young folks won't pick up a phone, so they like the chat option, but most of us with a little gray hair, we prefer to talk to something, right? And so that is absolutely one area. And that, believe it or not, we don't have to invent a lot of that, because there's a massive $3 trillion industry in call center related type things across the economy. And so we get to arbitrage some of those technologies over on our side. When it comes to like uploadable wearable things, man, I would love that. but it sort of goes to the idea of the competency of the models to process those other types of data. And I haven't seen it. I'm waiting for something like for example, an Apple or a Samsung or someone that's really deep in the wearable space to help us, figure out what information is useful, how can it be, service to physicians to aid in their care. That's still early days, if I'm honest. And again, you could show up to your visit with all of your prior heart rates and waveforms. I don't have time to look at it, number one, and number two, I don't even know what to do with it, to be honest with you. So I would need some kind of like interpreter for me too, to contextualize it for the visit.
Thanks.
Thank you so much, Dr. Lungren. There's so many other questions that we're not going to get to today. Perhaps participants can reach out to you directly to further the conversation.
Absolutely. Yeah, no, thank you, everybody. I really appreciate it. Hi from Redmond, Washington, by the way. I'm in this fancy exec meeting. Otherwise, I'd be joining you. Thank you so much, everyone. This has been really great.
Thank you.